has changed a bit in the era of lockdown and other travails. And this felt like I was stepping in uninvited to a very personal meeting. You guys seem to you had something that you were working on 1 hour, and I guess now you're transitioning directly into something else. Do you think should we allow people to have a little break in case they need something or other, or should we just proceed?
I mean, I think people are kind of going in and out, so I think we're probably fine just going ahead and getting started, unless anyone needs to.
Well, for screen sharing, let's see. Do I have to be a host to share my screen? Let me try clicking on it. And now it seems to work just fine. So let me bring up my presentation. Let's see.
There we go.
Share. Perfect. You know what would be very helpful for me is to have a sense of who is in the call and who I'm speaking to. Is this a group? Is this a multidisciplinary group or a single specialty? Do we have trainees and attendings? Who composes this group?
So this will be basically all family medicine residents and no faculty. So it'll be just residents of all kind of classes. So.
Okay, understood. And so all MDs, no nursing, no EMTs, just
MDs and DOs, but all physicians.
DOs, of course. Well, so I'll tell you a little bit about my background. So my name is Guillermo Linares. I'm a neurologist. I'm from Mexico City. I went to school back home, and we don't have DOs. But I've always considered them equivalent. My point of entry into the United States was the Cleveland Clinic, where we had a very DO-friendly program. And I particularly think that neurology benefits from the presence of DOs. So I've never made any kind of distinction between these. After the Cleveland Clinic, where I did a neurology residency, I got some training in New York City at Columbia in stroke and neurocritical care. So I'm an intensivist and a stroke physician. And then I did some training in interventional techniques. So nowadays I spend my time mostly doing procedural treatments for stroke, both on the ischemic side and the hemorrhagic side, plus the hospital care of the patients. And that's sort of how I spend my time. I'm the newest addition to the Department of Neurology faculty. It's been about 8 weeks for me so far, and I've been loving it. Most recently, I lived and worked in Vermont, at the University of Vermont, where I ran the stroke center, and I have been nothing but pleased with the gorgeous weather that received me here in St. Louis and what has been a lovely spring and early summer. Where is St. Elizabeth's? I haven't had a chance to get a good sense of the geography. How far away are you guys?
We are just about 20-ish miles east of St. Louis, basically.
I see. In which direction? Where would I have to drive toward?
East. So go on 40 or 64 east, basically the whole way.
Okay. So we would be the comprehensive or level 1 stroke center that would be closest to you in case of an emergency for your patients. Yeah, so that makes, I think, for a natural relationship, because unlike with many other things, I think one of the things we're going to talk about, and I know you know this, but the treatment of stroke is very time sensitive, and minutes do matter. So I'm glad that you gave me this chance. Hopefully we can do this every now and then, and I can tailor it to different topics. Originally, the topics that had been floated were stroke, TIA, maybe seizures, maybe tremors. That must be because these are some of the complaints, neurologic complaints that you deal with the most. Is that fair to say? So not wanting to speak out of turn, I think I will kind of narrow it down to stroke and cerebrovascular diseases. And even within stroke and cerebrovascular diseases, I think I'll narrow it down further to ischemia. The problem with the word stroke with this condition is that the term is a bit antiquated and vague. A lot of neurology is like that. Now, some of us gravitate toward those kinds of things. I think the stereotype of neurologists being somewhat intellectual maybe does fit. And in this case, I think it has hurt us because we're saddled with this term stroke that is very similar to other terms that we have dropped. And if you think about it, we no longer treat patients for dropsy. We no longer treat patients for consumption. There are these older diagnoses that have really gone away, mostly because of their vagueness. And so this dropsy or generalized edema, now we either diagnose as congestive heart failure or hypoalbuminemia from liver failure or nephrotic syndrome. And so we know what patients have and we call it that. Consumption will mainly perhaps tuberculosis, but other conditions, maybe lung cancer or lymphoma, they would present with a similar clinical syndrome. And nowadays we just call it what it is. Now, with stroke, something has kind of stuck and we still use the term, but at its very, very basic, at its most essential, what it really implies is that there is the sudden onset of a focal neurologic deficit. There are exceptions to all of these, of course. That was the original description. Sudden onset, sometimes you say apoplectic, like begins like that. You're fine until you're not, and then all of a sudden you lose function or something. So unlike some of the patients that you may be evaluating who have sort of neurologic gain of function problems, like migraineurs will see little fortification spectra or scintillating scotoma that are bright and have colors and move around. You could consider that a gain of function. Or if one of your patients, this happens more and more these days, you'll have someone in clinic and the spouse will say, well, look at what happened. And then they pull out the cell phone and they were filming their spouse. And what you see on the video is some kind of rhythmic movement of a limb. Well, we could consider that gain of function rather than loss of function. So most of cerebrovascular injuries like that, it simulates an ablative lesion to the brain. You lose vision, or you lose the ability to speak, or you lose the ability to move an arm or to move a leg. Focality is difficult. I mean, everything is kind of in the brain, the good and the bad. So we could get very philosophical and talk about, well, maybe happiness and sadness and love is in the brain, and where's the focality for that? Unfortunately, we don't know as much about those kinds of things. We know more and more with functional MRI, et cetera. But there are some basic systems that I think we can usually rely on as savvy clinicians from any specialty to know that there's neurologic injury. Visual system, language, the sensory system, the motor system for moving, coordination of the limbs, eye movements. These are signs of neurologic injury that are present. And most of the time, you're not paralyzed in both legs and both arms. Things tend to lateralize. It's one side or another. And so we talk about that as focality. But of course, if you have brainstem injury or certain parts in the brain, you can be paralyzed. So this is just a general guideline, I suppose. It wasn't until we started doing postmortems again. So, back in the day, Greek medicine, and we started to notice, even perhaps before that, during war, people would get hit in the head and the skull would come off, and you got hit on the head in the right and you were paralyzed on the left, and the brain was, the smushy part was coming out of a hole in the skull. So we made some connection to the symptoms. So once we started doing autopsies in a systematic way again in the 17th century, now we said, well, maybe apoplexy, and that became the term. That's an even worse one, I think, as something that is sudden onset, it's focal, it's neurologic, it's a deficit, and it's due to a vascular problem to the brain, because there are other causes for this. Perhaps the worst thing about the term stroke is that it literally means that you've been struck by the hand of God, or the lightning of Zeus, or the hammer of Thor, or whichever deity or supernatural. And so in trying to understand the vascular injuries to the brain, I think it is worth it to be a splitter rather than a clumper. I try to avoid saying stroke as much as I can. That's not to say that the term is wrong. I like to remind the residents when I work with them that most of the time the preeminent journals in every field are single word journals. And the preeminent journal for my field is called stroke. And so there, of course, is something to the term. I work at the Sauer Stroke Institute. So there's value in retaining it, but there's little specificity. So really, strokes come in two flavors. They come as ischemia and hemorrhages. Infarcts are much more common than hemorrhages. Infarcts comprise somewhere between 70-75% of all cerebrovascular injury to the brain. I'll speak briefly about the hemorrhages. Maybe that would be a topic for a separate didactic session. With the hemorrhages, we mainly approach them depending on where the blood is located, whether it's between the skull and the dura, like an epidural, though we don't really consider that a stroke, but it is blood in the brain, or if it's under the dura with the subdurals, or if it's in the parenchyma of the brain, or if it's in the subarachnoid segment, or if it's in the intraventricular segment. So depending on the location, we subdivide them up in that way because they have different causes. So epidurals are mostly traumatic, whereas subarachnoid blood is usually the result of a vascular malformation or an aneurysm or some other complex vascular problem. Let's focus instead on ischemia, and let's spend the rest of the 40 minutes discussing why it might be worth it to differentiate between the different types of ischemia. Well, ischemia to the brain happens due to different reasons from ischemia to the heart. So first of all, I probably sorted this out my third year of residency. So I was at the Cleveland Clinic, and everyone who was there wanted to be a cardiologist. And so I thought, maybe let's take the heart story and let's make it the brain story. And I knew the heart story. I knew what happened then. You had plaque, and there was deposition of foamy macrophages between the intima and the media, and there was inflammation, and then there was rupture of that plaque, and you would expose the contents of the plaque to the now denuded endothelium, and that would expose itself to the blood. Von Willebrand factor would come in, the platelets would stick, and all of a sudden you'd have a heart attack. And I went through my career early on thinking that really was how ischemia in the brain presented. But it turns out that it's not. Ischemia in the brain is really multiple different diseases. So we have an unusually high, because so large of a percentage of the cardiac output ends up in the cerebral circulation. And also because most other organs in the body are able to clear thrombi. So, AFibers, they probably have little thrombi in their toes and in their abdominal organs all the time that just get cleared naturally by endogenous TPA. Whereas in the brain, it's exquisitely sensitive, and in certain parts, you become very symptomatic. So this cardiac embolism mechanism, could we really consider it the same disease as small vessel disease or lacunes? Lacunes are very funny. Lacunes are caused by chronic hypertension. And they're little tiny vessels that get injured over the course of time by uncontrolled hypertension. And so they tend to present with ischemia in the territory of a single little tiny perforator. So are these two the same disease? Well, they are in the sense that they're both ischemia, but do we treat them the same? And should we institute secondary prevention in the same way? Well, I'd like to make a case that the answer is no. Now, does the coronary story play out in the brain somewhat? Sometimes it does. There is intracranial atherosclerotic disease, and it does lead to cerebral infarction. It's just not as prevalent, where virtually the vast majority of coronary cases you can assume are atherosclerosis related. Of course, there's dissections and there are other things other than athero, but there's a lot of athero. In the brain, maybe not so much. So is it worth it being a splitter? I think so. Should we lump it? Should we say, well, a stroke is a stroke is a stroke? Well, at least we have to split into the hemorrhage and ischemia worlds, because unlike with the heart, this is something that over the years I have become a bit defeatist about. There are so many patients that I see who tell me, there I was at home, and then I couldn't move my right arm and I couldn't speak well, but with my left hand, I opened the bottle of aspirin and I just swallowed 10 of them. Because there's this association with aspirin being a blood thinner and it's good. Well, we can't do that with cerebrovascular disease because it's very difficult to distinguish ischemia from hemorrhage on clinical grounds. We really do rely on technology to do that. Maybe the wisest position is to be a fence straddler and clump them up when it's convenient and split them up when it's not. Technology has changed the game here, and imaging by far. So CT scans became widely available in the 1970s, right? Technology was available before, but after the 1970s and certainly in the 80s, you could expect that you would show up to the majority of hospitals and you'd have access to a CT. So then we started to be able to tell the difference between bleeding and infarction. And then MR became available, and in the mid-80s, certainly by the early 90s, you could expect in most places that at least for certain days of the week, there would be a magnet available where we'd be able to see in great detail. So that if we look at the pattern of cardiac embolism over in this corner, where we have these little bright spots that represent cerebral ischemia, and they affect both sides of the brain, and they're small, and they're in the gray-white junction, and they're in the anterior circulation. This would be like the right ACA or watershed between the MCA and ACA. And also in the cerebellum, which would be the posterior circulation. So you have both sides, anterior and posterior, then that's probably embolism, probably from the heart. Recently, we've also figured out that embolism, when it looks like this, is not only from the heart, but that arch atheroma is a source of embolism that is probably important and that we haven't been talking about enough. Now, we were saying about taking the coronary story and putting it into the brain. Here's an example of that. So this is the right middle cerebral artery in an angiogram, and the caliber should be, by the way, when I use my arrow like this, can you also see what I'm pointing at? Okay, good. So if the diameter of the artery should be roughly this, but yet we see this little string sign. So this is the athero story, and it leads to large infarction. Now, what I'm trying to show you here is normal vessels. So that if we take a look at the circle of Willis, this is an MRA, and there's no narrowing, and every vessel is present and accounted for, because this is a small vessel pattern of infarction. What that means is that a single perforator originating from one of the larger vessels shut down because of hypertension. There are other less common types of stroke. So for example, all the way to the right of the slide, this is a venogram. So instead of taking a picture of the arteries, we're taking a picture of the veins. And what the arrow is showing is, well, first of all, there's no jugular vein, and we don't have the transverse sinus. And in the same side of the brain, on the same side of the brain where the transverse sinus is missing, there is an infarct that has blood in. And so venous infarction, although much less frequent, is another cause of cerebral ischemia. Now, I ask myself, if I'm not diagnosing someone with a mitochondrial disorder like once a year or maybe once every other year, then I'm not doing my job correctly, because with the volume of patients that we see every now and then, and they're difficult. So there are conditions like MELAS, mitochondrial encephalopathy, with lactic acidosis and strokes. There are other conditions that they might look on initial presentation as bread and butter, but they're less common causes of ischemia. Those are not the most frequent. It has been a trip, because within my, every time I do these Zoom talks nowadays, I see myself on the camera and I see that I have less and less hair on the front of my head. I used to have much more, but I still feel young at heart. And it's really within my tenure from starting medical school. Let's see, I started medical school in 1994. So it's really within my tenure that the story has played out. This is not an uplifting slide, though. 1,026 experimental treatments in acute stroke. And the story went kind of the same way every time. It was, we did something, it made sense, we had a basic science model for it, we tried it in rats, it worked great in rats, then we tried the translational research, and we took it to the bedside, and it didn't do much for people. And it was very frustrating, and it was an era within vascular neurology where our colleagues, certainly in the vascular world, would maybe look down on us a little bit, because they'd say, you stroke guys, you have nothing to do. You can't even tell a hemorrhage from an infarct. And, we're not even sure what the effect size of aspirin. So we were not the cool kids on the block back then. And things have changed dramatically. Certainly by the time that I was choosing a specialty in neurology, there were so many developments and so many new treatments that the tables have turned. Now, that's not to say that we should not be in awe of what deep brain stimulation can do for Parkinson's disease, or immunomodulating therapy can do for multiple sclerosis, or epilepsy surgery can do for curing epilepsy. So I think the whole field has experienced a revolution. But this is our legacy. This is where we came from. So what's the mission here? Well, the mission is that at some point, part of the circulatory apparatus in the brain shuts down and there's not enough blood going to a part of the brain. Now, that probably does not result in immediate infarction. It's time dependent. So that at the center, there might be a small part where there is what we call core of neurons that become injured. And surrounding that central core, there's probably expanding areas of threatened, but not quite yet dead neurons. And that's the goal, is to save as many of those as possible. And that's why speed is so important. We learned in the early 2000s that if we opened up vessels, people did better and they died less. Now, we mostly were looking at patients who got TPA and at patients who spontaneously recanalized. We didn't know back then if we could open the vessel with a catheter and cause a good outcome to be the result of it. Now, it's been a little while, right? December 14, 1995, this became available. It's actually interesting. Between 1995, so that was my second year in med school, it took about another 10 or 12 years for the drug to be used consistently and in large scale. That was the main reason why stroke centers were sort of organized, because even though we had the tool, we weren't using it frequently. The next development was to broaden that window. And it took from 1995 to 2008 until we got this next benchmark of treatment. And when we said, well, you can use it within 3 hours, you can also use it within 4.5 hours as long as you're careful in who you're giving TPA to. Now, the problem with this is that it was a fantastic advancement. It was part of the reason why I went into the field that I'm in. But I think it sends a bit of a confused message in that it might make someone think that there's something magic that happens at 3 hours and 1 minute or at 4 hours and 31 minutes, like the stroke fairy comes and pours infarction on your brain and you're done. And that's probably not true. What is actually probably true is that between all of us listening to looking at the slide, some of our brains would be able to tolerate ischemia more than others. So since I'm the oldest in the group, let's say that I might not be able to tolerate even an hour and a half or 2 hours of an occluded middle cerebral, but perhaps one of you is into the great outdoors and you like kayaking and you're physically active and you've made all the right decisions in life. Well, plus your genes, which we can't change, but that counts in because collaterals have a lot to do with genetics. Maybe you can tolerate up to 6 or 7 hours and you still have a lot of penumbra and small core. But the problem is that back in 1995, when we did the TPA trials, we didn't have advanced imaging to find penumbra, to find core, and we weren't even doing vessel imaging. So you don't need a CTA, you don't need vessel imaging to give TPA, because in 1995, we weren't doing vessel imaging. We've landed in an interesting spot where we're behaving TPA-wise a little bit as if it were 1995. Now, this is 2008 when we broadened the window, but in the United States, this is still off-label use of TPA. Now, the American Heart Association, the American Stroke Association has defended everyone. There are guidelines, there's recommendations, but in the 3 to 4.5 hour window, it's still an off-label use because a US trial was never done. This trial from 2008 is a European trial. So when the FDA said, if you want to have a change in indication from us, then you have to do a US trial showing that this works. And all of us said, no, we're not doing that. Because if it's my mom, I'm not randomizing her to some placebo. I want my mom to get TPA because none of us thought that. And this is a very, very rare thing to happen in the US. For most things, particularly drug-related, the FDA mandates that a trial be performed within the United States, sometimes with international collaborations, but certainly with a large cohort of US patients represented within it. And that trial was never done for prolonging the window. So TPA is great. We've certainly become huge advocates of it. But part of the problem is that only a small percentage of patients are eligible for it. And there's a risk of hemorrhage because it's systemic. So that if you have an ulcer in the duodenum, or if you have some kind of telangiectatic lesion in the colon, or you come up with your own reason, TPA might open up a vessel in the brain, but it might also lead to hemorrhage elsewhere. But the main, I think, issue with TPA is that for the larger vessels, so it works very well for small distal vessels, but for an MCA, like the one that I was showing you with the large infarct, it only opens those up in about 10% of cases. Now, those lesions don't open up on their own more than 1.5% of the time. So it's better than nothing, but it's nowhere near enough. It's a neat little drug. It just kind of augments what we have as our own internal machinery. By the way, you're welcome to have my slides. If anyone wants them, I'll give you email and you can ask for them. I'm going to skip a little bit over the specific pharmacodynamics and pharmacokinetics of TPA. I could spend another hour with that, which I love, but
Dr. Linares, if you just email that to my email,
okay,
I can send it out to everyone.
Yep. And as long as you tell them that you met a vascular neurologist from Mexico who works at SLU, you can use my talk when you go and give it and make it your own. It's perfectly fine. So I always liked it better when I was a resident when we talked about cases, and when we sort of played around with hypotheticals. It was just clearer for me. Um, Before being a neurologist, I was a categorical internal medicine resident. I later on switched, and something that was helpful in the switch for me early on is to realize that there's a reason why neurology is a separate department. If you think about it, like hepatology is not its own department, right? Hepatology is part of medicine. Cardiology is part of medicine. So what about the brain makes it that we are in our own category? And many times when I ask this question, at least when it's live, someone will suggest that it's either a historical accident or that some political scheming had to do there in the background. And maybe someone might point out that in different countries, like in Europe and India, that neurology is part of internal medicine. But I do think that there's a good reason for neurology to not be one of the medical specialties, because at its core, the neurologic method, the way that we approach patients, is fundamentally distinct from how medicine does it. And this is a boiled down way of how a stroke neurologist would think when dealing with an acute situation. And I think it relies a lot on neuroanatomy and localization in order to sort out the mechanism. So while whether you have a lesion in the quadrate lobule of the liver or the left side of the liver, these lesions can still be neoplasm, they can still be infectious, they can still be abscesses. The localization does not determine the mechanism or the etiology of hepatic lesions. Yet in the nervous system, starting with the most basic answer, is it central or peripheral? It's one of the core things that differentiates things. So if you have someone with a paralyzed face, right, if you establish that it's a peripheral lesion, then it's likely a viral infection of the seventh cranial nerve, and you don't have to be worried about a cerebrovascular cause, because there's no way of getting a peripheral. There actually is if you have a nuclear puncture, but the bigger principle still applies. Whereas if it's a central syndrome, then you put vascular causes in the mix. So it can be very important if you're in clinic and you see someone and you see that their face is paralyzed, distinguishing where the lesion is drives your decision-making as a physician, probably more than in any other specialty that I've come up with. The other thing about the neurologic method is that it's a little bit independent of imaging. We do need imaging to establish if our theories are correct or not. But the neurologic exam continues to be the best tool for localizing. What imaging has done is given us a window into the black box of, is this a tumor or is this an abscess, for example, which we weren't able to do without an autopsy before advanced imaging became. We just knew where the lesion was. But nowadays, the neurological examination continues to be the best tool for localization. And it helps us not overinterpret all the other stuff that we see in MRI. So every time you get an MRI, there's 17 different spots and 17 different abnormalities, and which one is actually the symptomatic one and how do you deal with it? It's still the exam that drives that thought process. So maybe I'm dating myself. I hope that you'll recognize him. First of all, I think he's a Mizzou graduate. So there's a Missouri connection, and his name is John Hamm. He played this character in a television show, Mad Men, where set back in the mid 20th century, and this is what he did the whole show. Is he just smoked and drank, and they had horrible lifestyles. Right, the perfect thing for a stroke patient. And eggs have a bad reputation. I think. I particularly, personally, I eat a lot of eggs. I think they were maligned. I don't know that they have the impact on cholesterol, but for the purposes of didactics here, let's say that high cholesterol and smoking, and he's probably chasing it down with a screwdriver. He comes to the emergency room. His wife called 911. He was making breakfast at 8:45. Not wink wink. That might be relevant. When he falls to the floor, he's unable to speak. And he's unable to move the right arm and the right leg. So what about his physical examination? Well, his blood pressure is high. His heart rate is irregular. I should probably have put something like irregularly irregular. He's satting well. He's awake. He's alert. He looks scared and anxious. His head and his eyes are pointing toward the left. He cannot talk. He seems frustrated. He cannot yes and no, though. So if you ask him, is your name Mary? He'll say, no, and he'll look at you funny. Is your name Peter? Or in this case, John. If he'll go like this. But no words are coming out of his mouth. He has paralysis of the lower part of the right face. He has paralysis of the right arm and the right leg. But when you prick him, when you use a pin, he can feel it. And he seems to be able to see on both sides, even though his eyes are kind of looking to one side. So the next step in the neurologic method is where can this lesion be? I suppose it's always possible that he could have a cranial neuropathy plus a plexopathy in the brachial plexus, plus a plexopathy in the lumbar plexus, plus like 17 different lesions. But if we want to be parsimonious, if we want to say what's the one spot where this could be located, probably the left frontal lobe. So let's see, he's paralyzed on the right. So, and it's contralateral. And then his aphasia is a motor aphasia, or what some people call Broca's or expressive. So he can't speak, and that's frontal, but he can understand. So he doesn't have a receptive or sensory or Wernicke's aphasia. So the temporal parietal region must be okay. He can see, so the occipital lobe is fine. And he can feel, so the parietal lobe is fine. So this is mostly a left frontal problem. That's the exercise that we would have gone through. So sometimes at this moment, I pause and I ask myself, well, is this brain stem? Probably not. Is it right frontal? Well, no, because then the crossed findings, those don't apply. The left parietal and occipital lobes are involved. Well, no, because he can see and he can feel. Or the least likely would be he's got all kinds of different neuropathies affecting him. So what caused it? Well, you're seeing him and you get a 12th lead and you see this. And you now know where the lesion is. And so what you start to do is you start to gather clues to what could have caused this. So if you were to find, for example, that he is a smoker with 20-pack years, and you get a chest x-ray, and you see a big old nodule, maybe more than one lesion, you examine his neck, he's got lymphadenopathy, then your mind is now thinking, well, this probably neoplastic. Why do I bring this up? Well, there's a common error that we all make, which is that when we find something focal, we always want to make it stroke related, as if focality is equal to a cerebrovascular cause, which is not necessarily true. The syndrome would be the same from an abscess in that area or a tumor in that area. But if you see this EKG, well, now maybe you're suspecting, because what we're seeing here is, of course, atrial fibrillation, and now the plot starts to come together. So we saw his blood pressure, his INR, PTT, platelet count are normal, blood glucose is normal, no recent surgeries. He does not take anticoagulants. What this is meant to show is this is meant to show nothing, which is really what we should see when we're looking at CT scans of viable brain. So a lot of CT scan changes take some time to develop. There's no hard and fast. It's not that it takes 3 hours or 5 hours or 12 hours. It depends on how quickly edema sets in, because that's really what we see. So the first wave of edema depends on the size of the core plus how vascularized you are. So this is a smackdown normal CT. It's funny, so when you look at CTs, the gray matter is white and the white matter is gray. So it's all kind of backwards. And there's gray matter deep in the brain. So if you see like there's a little circle there, that's the caudate nucleus. And there's a little circle there, that's the thalamus. Those are gray matter, so they look whiter. And then the gray matter on the surface of the brain, that also looks kind of white. Most of what we do to find early ischemia It's like looking, I don't know if you guys like painting, but if you look at a Monet from too close, like the water lilies or something like that, then you really can't make sense out of what's happening. You have to step back and let it come and look for symmetry. And you're looking for gray-white differentiation missing from either the deep structures or the very cortical structures. And you window your studies appropriately in order to be able to do that. So what should we do for treatment? Well, TPA is contraindicated because of time last known well. No, he was in the company of his wife and this was witnessed and she brought him in right away and he's within 4.5 hours. I think he's good. TPA is contraindicated because his blood pressure is too high. Well, it was 175. Now, I don't know why we did this, guys. It's very annoying. We give TPA if the blood pressure is up to 185, but then we say once you've given TPA, the blood pressure has to be less than 180. We could have picked the same number. And I'm not even sure that our tools, when we use antihypertensives like injectable or drips, that we can measure that 5 millimeter of mercury difference. But that is what it is. But his blood pressure is at a reasonable range. We can say that TPA is contraindicated because his CT already shows a large infarct. Well, no, that's not true. CT looks fine. And so there's likely a lot of viable brain. TPA is contraindicated because his platelet count is too low. Nope, the platelet count was fine. Or let's stop talking about it and give it already. So we do have to be thorough, but it's one of these things where sometimes we feel like we have up to 3 hours or up to 4.5 and it's been an hour and you maybe slow down a little because you think, oh, I have up to this amount of time. The sooner you give it, the much better it is for the patient. So yes, let's give it. Now, I didn't show you this part of the brain before, but the other thing that you see on the CT is you see this brightness on the left. Remember, he had like right-sided weakness, so it was the right face and the right leg and the right arm. So there's this brightness there, and that's not really located in the brain. It's outside of the brain. You see the other structure actually right here, but this one's not white. What that represents is a thrombus within a blood vessel. We call that the dense MCA sign. When we see these, you can hang your hat that there's an occlusion there, especially when it fits with the clinical syndrome. But you don't always see them. And if you don't see it, it doesn't mean that there's no occlusion. But in this case, I'm giving you quite a prototypical one. This is what we've started to do in the majority of our patients nowadays. This is giving contrast and creating a cast of the vessel, a luminogram, same thing that you're doing for the chest for pulmonary emboli, same thing that we do in the legs. Well, we just do it of the brain, and we're quite good at detecting large vessel occlusions. This is a coronal cut, so it's slightly different from the CT that I showed you, but right here, if we follow this one, it comes and goes and goes and goes and goes. Whereas this one, as we follow it, follow, boop, and then it stops there. But notice something. See all these vessels over here? They're still there. So collaterals are allowing for the blood to still get to where it has to go, even though there's a large vessel occlusion. This is a combination probably of his genetics, like we discussed, plus his lifestyle choices, plus maybe he's just lucky and it's a good day. What we don't know is how long those collaterals will allow him to have non-infarcted brain, and when will the brain become infarcted. Here's another key thing to know. Clinically, penumbra and infarct look the same because the penumbra is hypoperfused. There's not enough blood getting to where it has to go. So that part of the brain doesn't function. Just because there's a very symptomatic patient doesn't mean that the core is very large. It could be all penumbra. So if you open it, maybe it reverses. Those cases are amazing because we open them up. Those are the ones where, no kidding, couldn't talk, staring to the left, paralyzed on the right. Then you open the vessel and things improve dramatically. Most of the time, it's a combination of some amount of core, some amount of penumbra. Now, what we can do also is we can give contrast, and then we can measure the amount of blood flow specifically to the brain. This is called a CT perfusion study. And with CT perfusion, we can differentiate penumbra from infarct core. This was the next big turning point. It's like a stent on a stick. So instead of having the stents that you're used to seeing for the coronaries where they're mounted on a little balloon and you inflate the balloon and then the stent stays, this one's on a wire. And so you put the stent into the clot and then you yank on the wire. Now, that is the silliest thing I've ever heard. If someone had described this to me as a way to treat, I would say, no, don't do that because you'll hurt the brain arteries and there'll be problems and there'll be hemorrhage. The way that this device was created, there was an interventionalist in Europe who was treating an aneurysm. And so this device was being used to put over the neck of an aneurysm, and then a catheter would come in and it will go through these holes, these struts, and then a big coil mass would be deployed, and then the stent would be removed, but the coil mass would stay. That was its original purpose. But one day he had a complication, a clot formed in the vessel, and he deployed this into the clot and he yanked on it and it was all fine and the clot came out. So that was a game changer. He reported it. It's actually a neat paper to read. So what does that mean now? Well, it means that we can turn this here, where you have an abrupt cutoff of the artery. You could turn it into this, where the artery is normal. You can do it reliably. You can do it up to 80% of the time, which is good. Here's another example. You can turn this into this. Now, why am I showing you this one? Well, see these arteries? The whole point is to have these arteries open. Now, those arteries are open here. Well, where's it coming from? Well, in this case, it's coming from the anterior cerebral. So this is the middle cerebral right here, and this is the anterior cerebral. So the anterior cerebral is sending its little branches at anastomose and supplying the middle cerebral artery territory. Probably that's what kept that part of the brain alive. Now, what you guys will deal with in clinic frequently is the question, well, what is optimum secondary prevention? Well, for this particular patient, optimum secondary prevention depends on figuring out what the mechanism was. So I gave you a case where we found atrial fibrillation. It was an occlusion of a large vessel, probably by a thrombus. So probably we should use an anticoagulant, which seems to be the better way of treating stasis. There's this guy. You know this guy? So it's amazing how so long ago this concept could have come up. It's still valid today. I still think about it every time I see a patient with ischemia, right? Somewhere in this balance of either stasis of blood or vessel wall injury, which would be athero, I think I would put in that, but not only athero, right? When you have autoimmune conditions like vasculitis or varicella zoster that affects or now maybe even SARS-CoV-2, right? There are all these reports of the virus attaching itself to the ACE receptor, which is in the endothelium and leading to microthrombosis, which is manifesting itself systemically. I don't know too much about this, but I find it fascinating. In this case, I think probably an anticoagulant would be the way to go for secondary prevention. Because of time, maybe I'll stop there, and it'd be great to be able to have a little bit of a conversation in the last 10 minutes. I do have a second case, so when you share the slide set with the group, let me see if I can show you what the second case was. Because with this one, I really date myself. He's also smoking. Don't smoke. Yeah. Like there's a whole generation of people that grew up with these were heroes, you know? But let's leave case 2 aside. It's just a reiteration of the same method, right? What's the clinical syndrome? What does a physical exam show? Where's the localization? What is the mechanism? And that's how you know what to do. And let me X out of this. Don't save. And I'll switch myself back to full screen. I'll do that.
So if you just stop sharing your screen, that's probably the quickest way.
That's the best thing. Stop share. Okay, perfect. Yeah, so what is your point of contact? What is your most frequent point of contact with stroke patients? Is it clinic or the hospital? It's probably clinic and family, right?
Probably for most of us when we get out of residency, that will be the case. But right now it's probably on our inpatient service and our time when we're in the ED. So we are seeing quite a few coming in through the emergency room with stroke symptoms. So.
Yeah, that's interesting. It can be very challenging if you're doing the inpatient care for these folks. Um, you know, horses are way more common than zebras, but I do invite you to every now and then, if you're not finding a venous infarct or someone with a mitochondrial disease, if it's 2-3 years and we're not thinking of it, I tell myself I probably missed it because they are out there. That's me being a splitter. If I become a clumper, the same advice is good for everyone, right? Increase your amount of physical activity, make healthy lifestyle choices, diet, exercise. The impact of exercise, even a small amount of exercise, like walking briskly for 30 minutes a week. Like walking briskly 30 minutes a week doesn't seem to me like all that much. The impact on secondary stroke prevention is tremendous, tremendous, tremendous. And I don't think we emphasize that enough. I don't mean to sound jaded, but sometimes we're a little bit in the pocket of our drug company colleagues. And so, yes, statins are definitely high intensity statins. They're good. Aspirin, Plavix. Not everyone should be on aspirin and Plavix, but I think that's a good thing that we now know of a subset of patients that do benefit. There was a trial here in the US that looked at TIAs and very low stroke scale patients. And you got aspirin plus Plavix for 21 days. People did better. So I've changed my practice to that, but only for 21 days. The more frequent thing for you guys, if you do this, is probably they'll stay on dual antiplatelets forever. And that wasn't the point. That wasn't the intention. So now that this information is disseminated, I spend a lot more time discontinuing the second antiplatelet when I meet someone in whom it was initiated. Do you know what I mean? Have you noticed this? Have you seen that indication, a cerebrovascular indication increase for dual antiplatelets?
Yeah, I feel like basically everyone we're seeing is getting it, but I agree. I think at least when I see them in clinic, then they're often just never coming off of it. And that's where I think this is helpful to hear from you too, and to empower us to be willing to stop that, because sometimes they don't have a neurology appointment for some time.
Yeah. The discharge summary is key in this scenario. So let's say that there were a patient from SLU that we took care of, but they live closer to you and they like your hospital better and they feel comfortable with their family practice physician. Do you have good, consistent access to our discharge summary where we would ideally write 21 days worth of dual antiplatelets?
We can request it. I wouldn't say it's like necessarily.
How crazy is it in the most sophisticated, wealthiest nation in the world that spends such a large percentage of its GDP on healthcare? We can't sort this one out. But you're not alone. Like, this is a problem on a national level. I've lived in different places. I've been working for a little bit. I'm frustrated enough. I just noticed there are 4 chat. Let's see. Can message him if they have further questions. Yes, please. And then someone wrote C. Is there a Latino in the group? All right, but none of those were about to talk. What else? We still have a couple of minutes. What is a scenario that you face with cerebrovascular patients that you think would be helpful to discuss?
So usually when I see patients in clinic after a stroke or when we're discharging them from the hospital, we see the dual antiplatelet therapy for 3 months rather than 3 weeks.
Yeah, it's hard to comment on what other people might be thinking, but here's where you get to that. It's actually a little convoluted. So we did a trial of stenting in the brain, and we compared stent versus no stent, and the stenting group did worse because we caused hemorrhages. Now I think the technology will improve and that will overcome that, but in that trial called Sampras, the stented patients were receiving aspirin and Plavix. So the trial design called for the control group to be on aspirin and Plavix as well. because otherwise you couldn't compare. It would be like apples to oranges, and they were scared that people were going to say, yeah, the stenting group did better, but they did better because they were on aspirin and Plavix. So the control group did not get a stent, they got aspirin and Plavix. Their recurrence, the recurrence of cerebral ischemia in that group was lower than in some different study called WASID, which was done many years ago by the same investigator, Mark Chimowitz. And what we all concluded was, well, look, that group did much better than the single antiplatelet group in a different study, so let's start doing that. And the length of time for antiplatelets was there. So what I'd say is the level of evidence for choosing a 3-month duration is way smaller for the level of evidence of choosing a 21-day duration in the low stroke scale patients, right? If you have intracranial athero that's severe, then probably those are more similar to the stenting group, because those are the patients that do well with stents. And then 3 months might be a better goal. All of this should be clearly delineated in the discharge summary for you guys, so that you know the thought process of the person that was caring for the patient. Yeah, I know it isn't always, and that's also a chronic problem for everyone. Yeah. It's like carotid disease. You know, when we did a lot of the carotid endarterectomy studies, there were no statins and there was no Plavix.
Huh. So
now we're doing a 3-armed study of one arm is stents, the other arm is endarterectomy, and the other arm is just statin and antiplatelet therapy. And honestly, I'm not sure if they're not going to be either equivalent or because you don't have the procedural complication. I don't know what is going to happen. This is a trial called CREST, and probably by the end of next summer, we'll know more. So it's exciting times. There will always be patients who require interventions, but medicines work. All right.
I just have a question about like hard indications for endovascular intervention. I mean, we don't have that available at our hospital. So if we're seeing patients in the ED, what's your perspective on when they absolutely need transfer for your evaluation specialty?
If you have someone who is severely symptomatic, meaning if the symptoms didn't go away, life would no longer be good, right? So in very high functioning people, like, you know, if you're an airplane pilot, if you lose half of your visual field, well, that's super debilitating. So that's for that person. If you're older and you're in a wheelchair and really you only use, you know, for television and you don't move around, you no longer drive, some people might not consider that as debilitating. But so anything that's debilitating, certainly if you're paralyzed and can't speak and those kinds of things, should probably trigger a CT. If the CT looks fine, then that probably means you have a small core. If the CT looks horrible, then toothpaste is out of the tube, kind of. Mm-hmm. If the CT looks fine or fine-ish, then your next question is there a large vessel occlusion? So you would need a CTA. Now that I don't know. How accessible is CTA for you in the ED?
Very accessible, yeah.
Because there are 2 approaches that work here. One is to say, get them on an ambulance as quickly as possible, get them to the closest stroke center. Let's not waste time with the CTA because our team could be a little on the slower side. Or the other one is, no, we can get it in a matter of minutes. So let's answer the question. If there's no large vessel occlusion, you could prevent an unnecessary transfer. In this case, it doesn't sound like we're too far away from one another. So it might not be the end of the world. But in some of the more rural areas, sometimes people end up traveling, you know, really, really long distances. And then when they get to their destination, guess what? There's no large vessel occlusion. It's very frustrating, disruptive for families, et cetera. Yeah. If there's a large vessel occlusion and the patient is symptomatic and it's debilitating, then sound the alarm, and that's a great case for an intervention.
Thank you, Dr. Linares. That was, I think, really helpful. Couple examples there that we've all, I think, see or could imagine ourselves seeing. So I really appreciate your talk, and would love to have you come back for maybe some of those other, you know, topics that we had talked about another time. So
yeah, thank you so much for your time. It's nice to meet everyone, and I'll see you soon when the world reopens. Maybe we'll run into each other at a baseball game or something.